Hello, 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 everyone. My name is Hope Iore. I'm a fourth year medical student at Rush Medical College, former chapter president of Rush SNMA, and welcome to the start of the Sowing Seeds specialty series for otolaryngology. I hope you look for otolaryngology. If you are, you're in the right place. But this series is part of our Sowing Seeds program, like I said, created by our esteemed national president, Asose Obo, in collaboration with the Alumni and Multicultural Affairs National Committee. Throughout this year-long program, we've been providing resources on how to succeed as a pre-med and a medical student, touching on everything from financial literacy to preparing for board exams and things beyond that. So make sure you're a national member. You don't want to miss out on all the sessions we've got coming up in the future. Go to snma.org, sign up, and stay in the know. So without further ado, I can get into our panelists we've got this evening. First, we've got Dr. Javier Howard. He's an otolaryngology resident, PGY2, as you can see below. Tell the people what up.
Hey, good afternoon. How y'all doing? I'm Javier Howard, originally from Flint, Michigan. Went to Michigan State University for undergrad. Did a master's in public health there as well, and then down to the Natty, down to Cincinnati for med school, and now here in the Bay Area at Stanford as a second-year resident. Happy to be here. Former president of the University of Cincinnati College of Medicine chapter of SNMA.
Salute, the Natty. Is that Region 2? I don't know. I hope so. Legendary Region 2.
No, Region 5, my friend. Region 5 is live. It's raw. It's Region 5, baby.
Region 5. All right, second best to Region 2. I'll take it.
Hey.
We've got also on the line with us Dr. Otolaryngology Sajadi. She's a PGY1 resident, currently in Minnesota, I believe. Tell the people hello.
Hi, I'm Otolaryngology Sajadi. I'm an intern at Minnesota. I'm from the Bay Area. Did my college at Cal. Go Bears. What did I do after that? I did my master's in Puerto Rico and my med school at Creighton. I'm the former Region 2 director of SNMA. And yeah.
Shout out to my captain, Region 2 director of SNMA. Current in my heart, but former as of laws. Last but not least, we've got Dr. Rhonda Alexander. She's an assistant professor of otolaryngology down at UT Houston. H-Town, stand up. If she could say hello to the people. If not, she'll join in with us later. I'll give it a couple of seconds. She said hello in spirit. That's the part that matters. But from here, we'll move on to kind of the more bio parts, have our panelists talk, and we can get to know them. But what I'd like you all to touch on is where you trained for medical school. I know you already said that. How did you choose otolaryngology? Did you have mentors in your field? And your favorite thing about otolaryngology? Dr. Howard, I'll have you start.
Okay, sure. Well, first, I'd like to start by saying how good it is to see you, Arfe. She was actually a med student on the pediatric otolaryngology service here at Stanford when I was a sub-I, I guess 2 years ago now. Time really flies. But good to see you, your face. But yeah, so I already mentioned, to touch on where I'm from, the A10 in Michigan. Went to Cincinnati for med school, had an incredible experience there, was incredibly well supported there. And I would say that one transition that I made during medical school was having the realization of how important it is to have, of how important mentorship is, and how important it is to have a tribe of mentors. In undergrad, I kind of, I did a little research in the lab. I didn't really fully grasp or understand what was going on in the lab. There weren't many people in the lab that looked like me. Granted, they were mostly quite friendly, but my PI and some of the more senior people in the lab were maybe not as, I didn't really vibe with that well early on. And so I didn't really latch on to mentors in the lab or really in other spaces either that were going to be beneficial for me navigating my way into medicine. But once I got into med school in Cincinnati and got connected there is when I really started to realize how important mentorship was. I found otolaryngology through a mentor that I met in a mindfulness meditation course, actually, that I took as a night class, an elective offered by the medical school, not for credit. And it was actually the first year they'd offered the course. And there were 2 instructors for the course. Both were MDs. One was a radiation oncologist, the other a head and neck surgeon, a head and neck cancer surgeon, which is a subspecialty of otolaryngology, Dr. Keith Wilson, who's a key mentor of mine. Formerly the chief of staff at University of Cincinnati Hospital, also for a short time the chair of the University of Cincinnati College of Medicine, Department of Otolaryngology, and he still is an incredible mentor of mine. And he connected me to the next influential mentor of mine, Dr. Stacy Ishman, who was previously the president of the International Sleep Surgery Society. She's incredibly active in otolaryngology, in the Women in Otolaryngology organizations, as well as in sleep surgery and sleep medicine organizations on an international scale. And she is, one of the single most influential, mentors I've ever had. And she played a huge role in helping me find my way into my dream residency spot here at Stanford, which is coined the birthplace of sleep medicine. And she is at Cincinnati Children's Hospital currently. She's an incredible mentor of mine, and I'm so thankful to have had the opportunity to train at Cincinnati under the faculty there at the College of Medicine, as well as specifically the Department of Otolaryngology there. I was incredibly well supported there. But needless to say, as an intern, I got to scrub into my first surgery, not as an intern, as a first-year medical student. I scrubbed into my very first surgery with Dr. Keith Wilson. It was a neck dissection, and I can't remember whether it was, what the pathology was, whether it was an unknown primary cancer of the head and neck, and they were trying to figure out where it was coming from or what the situation was. I was a first-year med student, but I was amazed by the intricacy of the anatomy, and I didn't realize I liked surgery so much until I scrubbed into that case with him. And he happens to be, a Black male surgeon, and obviously representation matters. And having my first experience scrubbing into surgery so early in my medical education with a Black male mentor who's a surgeon in this field was really influential to me. And in my conversations with him in the months following that, I told him more about my interests. I have a special interest in sleep medicine and sleep surgery, and he let me know that I can be a surgeon and also treat people with obstructive sleep apnea, which is the specific disease process that I have a huge interest in. And that's how I got connected with Dr. Ishman through him. And from that point on, as a first year med student, every other field that I saw, I pretty much enjoyed everything from family medicine to general surgery to psychiatry, but I was comparing them all back to otolaryngology. And one of the things that I love and that a lot of people in otolaryngology love is not only the intricacy and kind of fine dexterity that a lot of the procedures and surgeries that we do require, from small otologic surgeries, manipulating the ossicles or the small bones in your ears, to, neck dissections and working around, the cranial nerves and the great vessels of the neck, but also the mix of medicine and surgery and clinic and OR. It's a really incredibly diverse field. And as a second-year resident, I'm still discovering little small sections of the field that I didn't realize exist. So it's an incredibly broad field, and you can make a huge impact on people's lives because we are the specialty of the senses, taste, smell, everything but sight, hearing, and facial expression and communication, the voice. So these are very important things and very central to people, their identities as well as their quality of life. And so that's something that I really appreciate about otolaryngology.
Thank you. Thank you for that. I said a lot. None of it was important. I'll just say it again. But thank you for that. I feel like you said so much. Some things I was picking up in that were the importance of mentorship. Mentorship you kind of stumbled upon when you're in your mindfulness and meditation class, mindfulness and medicine class, excuse me. And the relationships you built from that turned into mentorship relationships that turned into you find yourself at Stanford now. I feel like that can't be understated. Just the power of that relationship. I did want to introduce Dr. Rhonda Alexander. Like I said, she's an assistant professor of otolaryngology at UT Houston. If you could say hello to everyone on the chat. If not the second time, third time might be the charm. Let's see.
Come on.
We can kind of hear you in and out, but not quite.
Frustrating.
It is frustrating. I'm sorry for
Make
this.
it work. It was fine in the car.
In that case, we'll see if we can have Dr. Sajidi speak and tweak a little with your tech. So Dr. Sajidi, same questions. Were you trained? How did you choose otolaryngology? Mentors and your favorite thing about ENT?
Yeah, so I went to Creighton for medical school, and I know we're going to answer questions later. I see somebody had posted about how do you get into ENT research if you're not, you don't have an ENT department. That was me. I don't have an ENT department. My school doesn't even have an ENT attending. Our hospital didn't even have an ENT service covering. So it's possible. We'll talk about it. Well, for me, I think I grew up a lot with ENT. My dad happens to be an ENT, so he kind of showed me early on that it's just this field that he would come home and be really happy about every day after work. And he never complained about anything. He loved going to work every day. And I think that spoke a lot to me about the type of a field it is, the people that are in that field. I grew up with ENT as something that I just like heard about. I never understood that it was surgery. Until I was in medical school and I realized, oh, this is pretty cool. Like this is some pretty intense surgeries that you do here. So for me, I found a lot of really great mentors throughout my process. I'm a little bit of a non-traditional student. So I did my undergrad at Cal, and then while I was there, did a lot of healthcare disparity work. So I lived abroad in South America and the Middle East, kind of comparing their healthcare governments. And then I decided to pursue a master's in Puerto Rico, focusing more so on underserved medicine. And so I was kind of all over the place, and I didn't really have any research. And then in my year after my master's, I decided to do some auditory electrophysiology research over at Stanford. And I met a lot of my really close mentors during that time. And then just learning about auditory electrophysiology, learning about how we hear, learning about the intricacies of the hair cells and how everything works, it just blows your mind. It's hard not to be completely nerded out during those types of things. So yeah, I mean, I kind of found my way through research. I realized that ENT is one of those fields that you don't know about unless you get exposure to it. And if you don't have a department, it's really difficult to get exposure. So you have to be a little more proactive about getting to do sub-Is, getting to learn about the field. But it's also one of those fields that I think the majority of people I've met have been amazing. Like they're just really great people. Like Javier, I would love to be in practice with them one day, and hope whenever you're done, I would love to be in practice with you. And that's kind of how a lot of the field is. So I think it gives me everything I wanted in terms of it's diagnostic, but it's also surgical, and it could be more surgical or more diagnostic depending on how you take it. It's one of those fields that you can see old, you can see young, you can see men, you can see women. You're not limited in terms of patient population. And I think the most discouraging thing, and like a lot of us minority students, we want to come in and give back to our communities, and we feel kind of this burden that if we're not in primary care, we're not able to give back, and we're not able to do outreach. And that's totally not true, because even as an ENT, you're able to give back and do outreach. A lot of our underserved communities need subspecialty care, and they don't get it because it's oftentimes catered towards higher socioeconomic status populations. So we are needed as ENT in terms of outreach. And I think like for me, a lot of the mentorship that I looked for were people that were supportive. My medical school wasn't the most supportive in terms of getting me into ENT. They were worried because we don't have a department. They were worried that I wouldn't match. So like being able to be proactive and find mentors outside of my academic institution and just kind of email random people seeing if they would take me under the wing is kind of how I went about it. So it's definitely possible if you don't have an ENT department. I don't want anyone to feel discouraged by it. And I'm happy to talk more about my convoluted path. But ENT is great. I talk about it all the time. I think I try to convince every med student to go into it. You have great people you work with. The surgeries you do are mind-blowing. Even like the simple in-office stuff is really fun for me. So I can go on about it for a long time. But Javier touched on a lot of the same things that I would say. So yeah.
Made sure I'm not muted this time. But yeah, you said a lot. Fun fact for those watching: Dr. Sajadi is one of the main reasons why I even thought about ENT as a possible career for myself. I didn't even realize it was an option. I was thinking maybe like urology or something, and yeah, cut it off at the head and neck only. But here we are. So hopefully we can get back into our third panelist, Dr. Rhonda Alexander. If you could introduce yourself.
Hi, everyone. I am the moderately flustered attending who came home to a water condition in her home, which is just adulting is great. I'm an attending. I'm actually the residency program director at McGovern Medical School here in Houston, part of UT Health. This is my 12th year working at UT Health after my fellowship. I'm a laryngologist, so that's voice and airway disorders, but my fellowship focused also on neurolaryngology, so I do a lot of Botox or chemodenervation in the larynx and also in the face and head and neck for other dystonias and also for migraine. I'm originally from New York, and I went to Xavier University of Louisiana, which is the powerhouse for the manufacture and encouragement of Black physicians in this nation. We're number one. We're just number one. And then I went to Cornell University Medical College and did my residency at Albert Einstein College of Medicine in the Bronx, New York, and my fellowship at the New York Center for Voice and Swallowing Disorders, which is on the west side of Manhattan. And then I moved to Houston.
And I'm sure Houston has been your favorite part of your journey thus far. As a fellow Houstonian, I'm from there.
It's a very special place, for sure.
It is. That's the best way to say it.
It's 95 degrees right now. So
it's terrible. Humidity is the worst. I don't wear gray. It's actually awful. So you talked about your path through otolaryngology. So if you don't mind, I'd like to get into questions kind of generally for the residents we have on the panel. How was the transition from medical school to residency? How did you address that? What are some things you learned about yourself over that course? Dr. Sajadi, I'll start with you.
I guess I'm the closest to that transition. Honestly, it was a little rough because I hadn't done anything clinical since maybe October, and then COVID hit, and I didn't even see a hospital, and then you're a resident and you're an intern. And I started at the VA actually, and the VA is a great place. I think it's really interesting. I've never worked at one before, and you're just kind of thrown into it with a lot of responsibility kind of right away. And there's so much that you don't learn as a medical student, and everyone always says that. They say, oh, you don't know insurance, you don't know drugs, you don't know dosing. And it's like, yeah, we don't. That's true. But then you also realize you don't know that you are now the person that talks to other colleagues who are doctors, but you also talk to attendings and other specialties, and you have to explain to them your plan and stand by it, and they'll question you, and then you have to have the rationale ready, and all of this new responsibility of being the person with all the information, or at least figuring it out. So that has been really interesting. I think it's also exciting, though. The amount you learn in just like this 2 months that I've been an intern has blown my mind. From asking like what the dose of Tylenol is to now going to see consults by myself and diagnosing someone with cancer by myself and running it by a staff instead of just feeling kind of scared to even get a scope set up. So I think it's really humbling. There's also a lot of things that you don't learn in medical school, like the breaking bad news. That's pretty much a huge aspect of being an intern at the VA in my particular program. We have a lot of head and neck patients and a lot of people with biopsy results or CT results and things that come to my desk, and I have to be able to relay that information in a way that is understandable by the patient. And oftentimes when you're the consult, the first person that people see, you're the first person to give them this news or this information that there's something abnormal, there's something that you see on the scope. And that's like a very intimate opportunity, I think. It's just, you're either the person giving them the best news or the worst news. And I think that type of gravity was not in my like repertoire of things I learned in medical school. I think obvious things being obvious, like you're working a ton, you have a ton more responsibility, you're working with patients, you're able to say orders and people listen, which still blows my mind. But I think the biggest transition, change, or wild thing is being the person that people listen to, and kind of just managing how you got to relay that information and be confident and be well versed. And now when I come home, I study, not because I have to, not because I have a test, but because I genuinely feel like I need to know these things, because otherwise like patient care could be compromised, or my education or my impact on people could be compromised. And so I think it's incredibly humbling, but it's kind of a mess at the same time. So it's kind of fun. I don't know, Javier, does it get any better?
It definitely gets better. Do you remember you were my sub? It was my like first, second month, wasn't it? When you were visiting. How was I then?
What tired.
Yeah, so it definitely gets better, but it's a constant learning process. I mean, we chose a profession, medicine, where lifelong learning should be our goal, and certainly as residents. But our field is constantly, growing and developing with new, research findings and technologies, and so, we should be constantly learning. But things definitely things change. That's for sure, and for the better. I would say the question being the transition from being a medical student to an intern. Yeah, I remember that first week, not really even feeling comfortable prescribing ibuprofen. I remember I was on pediatric otolaryngology, like I mentioned, and it was a post-op tonsil, and I was like, am I allowed to prescribe this 3-year-old ibuprofen or Tylenol? Do I need to check a BMP or LFTs? Like, I don't know, to the point where now, those types of things are obviously very much routine. And my very first day, I remember being scheduled for the OR for my first tonsillectomy. Couldn't believe that my first day of residency I was going to be operating, right? But you get in the groove for sure. I think the big thing is that, the change is responsibility. As a medical student, there's always at least that intern whose true responsibility it is. And you have to always remember there are layers of responsibility. There's a reason that medical teams are set up the way they are, with a hierarchy of checks and balances to make sure that we are taking care of patients appropriately, safely, and giving them the best care that we can. So, keep that in mind and be comforted by that as you are starting off as an intern. Many of like you, Otafe, or those of you who are fourth years applying. But I would say, that transition is scary and it's challenging, and also from a time standpoint, you probably have never had the time commitment that you're going to have as a resident, spending 70, 80 hours a week in the hospital, and then going home and trying to read and trying to do other things that kind of make you who you are, make you happy, keep you happy and healthy. So it's a challenge. You have to be really intentional about your time outside of the hospital. And while you're in the hospital, I think it's important to just always ask for help. And I hope that all of you find yourselves in departments and in programs where the culture is to support your co-residents, to be there, to load the boat, because you are taking care of patients. It's a very sensitive job, more so than many other jobs. And so it's important not to feel overconfident or and make decisions that are unsafe for your patients. So I think when in doubt, always ask questions. I think medical students are high achievers, people that are very, very bright, used to being able to figure out how to find answers or do things on their own. But in medicine, once you get started as an intern, it's more important that you do the right thing and that you ask questions too much rather than too little, and communicate, over-communicate rather than under-communicate, because our job is so sensitive.
That's powerful stuff. Something I'm picking up from both you and Dr. Sajali is it's not about what you know. It's about it's more about it's not about what you know coming into intern year. It's how adaptable you are to learning through your intern year, which is reassuring to me as a fourth year, because constantly I've had percolating in my mind like I'm gonna have a lot of responsibility next year. hopefully. So I'm trying to learn as much as I can, but it's nice to know that the learning and the discomfort is part of the job description. So we've got a question from the audience. How do we go about getting research experience in otolaryngology if our medical school doesn't have an ENT department or affiliation? Dr. Sajadi talks about that a little. I want to toss that to her or Dr. Alexander or Dr. Howard.
Yeah, so I didn't have an ENT department, so I hear that stress, and it's just like triggering for me because it was an awful feeling, especially because I think a lot of med school has a lot of gunners who are like, I've done this, I have this 20 paper, whatever, and it's awful, and just ignore those people. I think what I did, and I think I tell everybody to do this, even if you have a department, is start cold emailing people. First off, any research is good research. So, well, okay, not any research, but like any specialty research is good research. So if you are doing neurology research because that's all you have at your school or that's what you're involved with because you don't have ENT, that looks totally fine. Nobody expects you to be an ENT master publication person, especially as a medical student. And true valuable research takes time. So expecting people to have all this life-changing ENT research done by the time they're applying to residency is it's a high bar that's really difficult to attain. So neurology research, cardiology research, totally fine. I had gen surg research. I even had family med poster on my thing, but I also had ENT research by my third and fourth years when I got a lot more ENT research. And the reason being is because I would email random people and I would look at departments that were close to mine. So Creighton, I was in the Phoenix campus for a while, and that was close to LA and Irvine and close enough. And I would reach out to them, and I would reach out to all the close medical centers that did have ENT, and I would specifically email the people that were either researchers that had something I was interested in, or I would just email like different minority faculty or like female faculty at that ENT program. And it worked for me. Like I got ignored by a ton of people. I think I only got one semi-rude response, but essentially it's like a cold email. I would say, hi, Dr. So-and-so. My name is Atifa Sajadi. I'm a current MS3 or MS4 interested in applying to otolaryngology. If it was a research thing, I would say, I'm very interested in auditory electrophysiology or cochlear implants. And I was reading more about what you were doing, and I would love to hear if you have any opportunities available for current medical students to get involved with your research. And you can mention that you don't have a program. And then I would send those same types of cold emails to network, because I think for a field like ENT, networking is critical. And I would send them to all programs all over as an M3. And I would say, hey, Dr. Alexander, my name is Atifa Sajadi. I'm a rising MS4 interested in applying to otolaryngology this upcoming fall. I would be very interested to hear about your path to otolaryngology if you had time in the near future. And then sometimes it's like you can stop by if it's a local place, or sometimes they would email me and I'd attach my CV and always say, attach my CV for your reference, and then sign, with warm regards, Atifa Sajadi. And then I'd have a headshot so that they could see, one, that I'm a woman, two, that I am ethnic, so that the minority physicians that I'm emailing tend to, if you see another minority, you're more inclined to respond sometimes. Or like you're more inclined to be like, hey, I remember being in this position and not having people that look like me in this field, so let me help. And shorter emails are better. So that's kind of how I went about it. I think it's possible. It's not easy. The other thing is reaching out to people that already made it and being like, hey, Javier, do you have any extra papers that you need help finishing? Like I've given a lot of my papers to current M3s or current M4s that are applying to ENT because I don't need to be first author anymore. I've already got my foot in the door, so open the path. So those are some suggestions.
Oh,
I think that's
great suggestions. Sorry, that's Howard.
Oh, you're fine. Go ahead. Yeah, I think those are excellent points. I think research is important for a couple of reasons. So I think she touched on some of the major points. A big thing is that maybe research isn't your strength in your application, and so I think it's important to highlight other things in your application that. And so if you have leadership, if leadership's your thing, really dive into leadership as a med student. Maybe you still need to find some research, that's for sure, but maybe leadership or community engagement, or there are other things about your application or about who you are and what you're passionate about that are going to stand out to programs. But with regards to research specifically, it's very important to at least have a little bit of ENT research in the works. In, like Otolaryngology said, if nothing else, for networking purposes, because it is an incredibly small field. There's somewhere between 315 and 330 spots a year in otolaryngology, and there, I think, are less than maybe 12,000 practicing otolaryngologists in the United States, something like that. So it's a very small field. In academic otolaryngology, obviously, even that much smaller. But with regards to research, it's not as much about the quantity of research. There are some programs that are going to be research powerhouses that maybe look more at quantity when they're screening applications, but it's more about high quality research, and ideally, but obviously a lot of the research you do as a medical student isn't all that high quality. You don't have time for that. But more so, it's about what did you learn from that research, and how well can you speak about the research? Were you really involved in the research, or did you really just kind of edit the paper and then submit it? That's what programs are looking for, kind of once you get your foot in the door. But that's what they're going to ask you about. They're going to ask you about particular papers and see if you really know the methods or what happened, or even just how to write a scientific manuscript. At one of my interviews, I got asked, so how do you write a manuscript? It was a paper I was first authored on, and they were really probing to see, did I actually write this paper from scratch? So I think it's important to have those kind of reflections once you have research. With regards to not having a program, again, like Otolaryngology said, the worst thing someone can tell you if you cold email them or call them is no, right? I mean, obviously you probably shouldn't be calling people, but cold email people, the worst thing to say is no. And maybe it's a little rude. Most people are not going to be rude. But if you think about it, asking for help is inherently a compliment to whoever you're asking for help, right? Because it's implying that that person has power or has something that they can give you to offer you. And so whether or not they decide to offer you that is up to them. But you are inherently complimenting them, and and most people would be either willing to help, or if they're too busy or they don't care, they just won't respond, and there's no loss for that. But I think it's important when sending these kind of correspondences, set up a template with little asterisks or parentheses where you should put names, or you could fill in different things, specifics for the communications, and then you can then copy and paste those into new emails and fill in the blanks, rather than writing a specific letter for a specific person and then copy and pasting and editing it, because then you're more likely to forget something, to forget to replace, Valley Medical Center for, Kaiser or something in the email. And that can be awkward or detrimental, where the person's really not going to respond because you, wrote the wrong information. But I would say, using some of those strategies of really broadly networking with, fourth year, third year medical students, residents at different programs that you can meet or that you cold email, and faculty at different places is important. Also, if you can, try to look for meetings. Right now, obviously in the era of COVID, there aren't very many research meetings that are happening in person, or any at all. But when these meetings take place in person again, if you can find funding, or if you can afford to go to some of these meetings, even local or regional meetings of otolaryngology, if you can find them, and kind of go around networking with people. Poster sessions are great for networking. Those kind of things can be really beneficial to find yourself research projects.
Thank you so much. Jan, I heard you say manuscripts, and instantly jumped a little, because I'm not a huge research person, but kind of those tips, especially about knowing the research you have done, knowing the well, is critical. I believe we got another question coming up. So earlier you mentioned being able to do outreach in your community while still being in a subspecialty. Could you give some examples of what those opportunities might look like? That's a great question. I had that question myself. Whoever wants to go first.
I'm back. Can you hear me?
I can, yes.
Okay. Again, thanks for putting up with the old on this live stream, which is me. So otolaryngology is actually an area in which we have significant health disparities within the United States. Obviously there are international opportunities for providing assistance through international mission projects, which are focused on otolaryngological care. But just here in the US, I can't remember her name right now, I apologize, but I think her name is Dr. Hamanaka. She's an otologist, and she recently published that even in the US, in urban environments with insured patients, patients from the African diaspora, African American, Caribbean American, African first arrivals, are less likely to be recommended a cochlear implant than white people. So really one of the most important areas of outreach is for us to literally just educate our own community about things that are available. And in the same way that that we almost all got to medical school not knowing that otolaryngology existed, patients also don't know that otolaryngology exists.
Yeah, that's critical. I did want to ask you a question we had before that you may or may not have heard while you were off figuring out the technical difficulties, but it was from one of our participants. How do we go about getting research experience in ENT if our medical school doesn't have an ENT department or affiliation? ENT research in specific looks good for applications, but it's stressed for applications. But for this particular participant, her research is in neurology. And she wasn't sure whether or not that'll be looked upon negatively as she's applying for residency. So I want to get your perspective as a program director. Oh no. I might have, tragic. Maybe we'll see if we can circle back to it.
I can answer a little bit about the other question though.
That'd be great, yeah.
Yeah. So I think that we have this misconceived notion, just like Dr. Alexander was mentioning, there's lots of healthcare disparities within ENT, particularly when you look at head and neck cancer. It's rampant. There's other things. There's hearing loss. There's children in lower socioeconomic status households, as well as all the red line communities have decreased access to like school adjustments to accommodate decreased hearing. And so those are huge things. Those are our roles as ear, nose, and throat. We see those patients. We see them fall behind in school because they have a hearing impairment and they've never been tested because it's not something that their red line school district is able to afford. So there's so many different ways. But then if you take away the ENT aspect of what we do, you are also still a physician. And so for me personally, my goal is to open up a free clinic, and it'll of course have ENT services, but I'm still a physician. I can still tell you, or I can still diagnose you with other things. Like I can tell when someone has diabetes. Will I know how to manage it? No, but I can still guide you to the right person and talk about why that's risky. And I think that was one of the most ironically inspiring things that I heard, because one of the ENT physicians that I was interviewing with this last year said, oh yeah, I'm an ENT and I run a clinic out of my trunk and I go to all the homeless communities around, this inner city, and I just kind of see them and I tape up their stuff. And I was just looking at him like, how do you have the time to do this? You're a whole ENT. And he said, well, I'm a doctor first. And I was just like, you're right. You're a whole doctor. You might be an ear, nose, and throat or a head and neck surgeon or whatever subspecialty, but you are a physician. You know how to do these things. You can still give back. You can still staff free clinics for those medical students. You can still give back and outreach. So that's one thing. Global surgery is a huge push right now. Actually, one of the faculty at Stanford on my sub-I and I were talking about it and trying to go on different, surgical cases together abroad, but with the goal of not necessarily coming in as this white savior complex and doing these amazing surgeries and then leaving, but instead altering your mentality and now training residents in other countries and teaching them how to do those same surgeries. And because they're local, they're able to make long-lasting impact. And you could still go and do these life-changing surgeries and leave, but you're not just leaving everything kind of to be on pause until you return. You're training the next generation of surgeons. You're giving back to your communities. There's so many different ways. And realistically, this whole field is open to us, to people like us that are excited and inspired and actually want to give back to our communities. Because everybody says that, everybody talks a big talk when they're applying to medical school and when they're applying to residency, and they're like, oh yeah, I want to help the poor, I want to save this. And it's like they become a rich doctor, they get a salary that's 500K, and then they forget about it. And that's totally fine too. But people like the people that are asking these questions, like, I know I want to give back. I will find a way to give back. Because I'm ENT doesn't mean I'm limited in it. Yeah, you might not be primary care and able to do as much as you like see on a daily basis, but you're still valuable. There's still hearing loss. And even right now, the World Health Organization and the United Nations came up with a global initiative for hearing loss. And so they're going around in all these different countries and evaluating hearing impairments. And you look at this, you could expand this to every aspect of ENT. You can expand it to head and neck cancer. It's huge in Persian populations. It's huge in Indian populations. It's huge in North African populations. There's head and neck cancer everywhere. Everybody gets it. So your role as a physician is not limited by you becoming an ENT. Your ability to give back is not limited. That's innate within you, and you'll find a way to bring that to your career.
Thank. I got to clap for that one. Your role as a physician is not limited. Your role to, I didn't get it right, but I remember it. It's up here.
Just to piggyback on that as an example, one of the otolaryngologists I saw in Flint when I was in undergrad, I found that I had a little nodule that I thought was on my thyroid. Turns out it's like a little calcified lymph node, I think. But Bobby McCullough in Flint, Michigan, he actually just got elected as the president of the, I think, medical board of Michigan or something like that. He took some major role in the state of Michigan. On top of that, he'd already been very active politically in the Flint area in Genesee County. And he actually bought a lot of businesses and storefronts. Actually, there were old brick buildings that were vacant that he bought in downtown Flint. And over several years, they are now filled with restaurants and shops and other businesses. And he played a big role or a sizable role in kind of the revival of downtown Flint, Michigan, where I'm from. And so your ability to impact the community where you find yourself, the community where you come from, is really up to you. What's your vision, right? But within the field of otolaryngology, a field that is, slowly but surely starting to diversify more and more each year, as there are now more and more ethnic, Black and brown, female physicians entering the field of otolaryngology, there's so many questions about otolaryngeal disease processes that haven't been asked before. And so we need diverse perspectives entering the field, in every field of medicine, but especially fields that are historically less diverse. We need these diverse mindsets, backgrounds, experiences to come into the field, start analyzing things and asking questions, posing research questions, and finding the answers to them, finding evidence of disparities and figuring out why these disparities exist, and to help fuel and feed evidence-based programming to help reduce these disparities. So we need people of all backgrounds, and that outreach to the community and that impact on the community you find yourself in can really be whichever way you dream, however you can design it, and however creative you might be. For me, one of my passions, like I mentioned earlier, is sleep disorder breathing, sleep apnea. And there are huge disparities in the awareness, diagnosis, and treatment of obstructive sleep apnea. And I don't want to touch on a manuscript that I'm actually working on right now too much, because I don't want anyone to jump me on publishing this. But that's a big passion of mine, is bringing more awareness to African American communities, to Hispanic communities. It's well documented that there's a much higher prevalence of obstructive sleep apnea and a more severe phenotype of obstructive sleep apnea, typically in people of Black African descent. But yet still there's a much less diagnosis and much less treatment at every level, from CPAP, which is one of the least invasive therapies you can do for obstructive sleep apnea. Obviously, the first line is weight loss in a lot of patients, but there are tons of surgical treatments for obstructive sleep apnea. But Black patients in particular are not getting to that point because they're not even getting diagnosed. Why aren't they getting diagnosed? In some places, maybe they're not seeing their PCP. But even when they are seeing their PCP, there's research showing that Black patients are less likely to even be referred to a sleep specialist. And then those that are referred to sleep specialists, a significantly lower number of them actually end up showing up to that first appointment. And that's before even getting diagnosed, which requires a sleep study or polysomnogram. And so there are a plethora of ways that you can get involved in, helping whichever communities you find your passion for.
That's amazing. I know for me, when I was considering where I want to go specialty-wise, what I want to apply into, was really worried about choosing a surgical subspecialty because I thought I'd just be insulating myself more, kind of taking myself away from that kind of like primary care, kind of like front lines vision of what I thought giving back to the community was. But just from the two of you, it's clear that that's not the only option. Yeah. A question I had for the two of you and Dr. Alexander, if she's able to get back in the mix. For other people in my position, fourth year students applying into ENT, I don't know where in the country I'll be next. But as you were in my shoes a year ago, 2 years ago, what things did you think mattered about residency when you're applying? And then now that you're in it, what things actually do matter? Y'all can think on it. I know that's a big one.
It's a tough question. I think I can tell you what things for sure matter. It's hard for me to think about what I thought mattered. But I mean, there are a lot of things I thought mattered that actually still do matter, thankfully. But I think a big thing is finding a place where you're going to be well supported personally, academically, professionally. So I think it's really challenging for you fourth years this year, and I really feel for you in that you're not able to go and actually get a sense of programs, ideally through sub-internships where you actually are able to immerse yourself in a program for a month and get at least a better feel for the program, for the culture, for the residents and the faculty, the way they interact, for their workflow and their work environments and their priorities. But I would say that that's really important because residency is really hard. You're taking care of patients. Patients will die. You're learning how to operate. You're learning how to, you're manipulating people's flesh, right? This is a very serious field. Surgical fields are very serious in that sense. Not only are you providing medicines, medical treatment for patients, but you're also literally cutting and manipulating flesh. So that's very, very serious. I would say other things that are really important, kind of getting a sense for what mechanisms are in place for resident wellness, whether that be the way that they handle call or in post-call, whether they have a night float system or in-house call. A lot of these factors are hard to know before you get to a program, but I think that's something that I thought was important and I still think is relatively important. I think more than that, how receptive the program is to feedback from residents and how responsive they are, because we are kind of on the front lines. And sometimes programs transform in ways that the faculty aren't aware of, that the residents are being impacted in ways that the faculty aren't aware of. And so if the residents are speaking up, are the faculty, is the program director, are they listening? Are they responsive? I think that's really important. But at the end of the day, you're spending more time with your co-residents than you will be with your families. And so ideally, you find a place that feels like a family where you really click with the people. And then ideally, you also find a place where if you have interest going into otolaryngology, specific interests, that maybe you'll be especially well supported in those interests where you end up. But it's really hard because it's a field like otolaryngology. A lot of times you just really want to match, right? You just want to find a place to train. And so I think that is most important because it is a competitive field, is find a place. And ideally, you find a place where it feels like home.
Okay, to Dr. Sajadi, and I think we might be coming up on our time soon-ish. So I'll pass to you.
Yeah, I think I can't stress enough that you want to be around people that feel like they're your people, right? And it's limited because it's a subspecialty, and you might not have anybody that looks like you necessarily. But you want to have people that are supportive, and if that's your co-residents or your attendings, because there's like a few givens in residency. You're gonna work a lot. You're going to work a lot of hours. You're gonna have really difficult days. It's just like a given. Surgical subspecialty, especially, like it's a surgical residency. You're working a ton. You're probably going to be far from people you love or not really present or miss out on a lot of things. But the one thing that you can kind of control is you don't need to be miserable all the time, at least. You want to be around people that'll make things better for you. So like for me, I don't have any family in Minnesota, but I loved my sub-I here. The residents, like there was not one of them that made me feel uncomfortable. My PD was a Latina female, and I love that. My chair was like a non-white male, like, so it was like, it's kind of abnormal. We had 3 Black female residents. We have most female residents and like most female attendings that I saw out of everywhere else that I went. And I loved it. And I felt like I vibed with it. And all the other people that were on resident, like all the other residents were great and they're super nice. And nobody made me feel uncomfortable. Like there was not a moment that I was like, that's kind of a sus statement. And it does really, really suck for you guys this year, because there's no better way to put it, because sub-Is tell you a lot. Like I did a sub-I at a place that I thought would have been my top 3 had I not done a sub-I, and it completely changed my opinion. So you have to try your best to suss out what the program vibes are. Like if you can, talk to people that are there, talk to people that have done sub-Is there in the past, talk to people who might know somebody there. Talk to me and Javier. We know a lot of ENT residents everywhere. We can connect you. I think that's important. So figuring out what type of people you're working with. And then for me, I struggled a lot with prestige versus like program training. And I think that's a difficult thing to like get rid of as a medical student, because you're always like around gunners. Thankfully for me, like I took name and prestige out of it when I was making my rank list, but I really struggled with it. So that was something that I think I thought mattered a lot more, when it's not, when like I know my program is this amazing program. What else? I think like the things you ask on like interviews, or it's like, do you get money or do you get parking? Like those are all important, but they're not they shouldn't be the deciding factors as to why you go to a program. But you know what should be, like if you have a family, or if you want a family, or even if you don't have a family and don't want a family, you should see how they treat residents that want that. Thankfully, I think ENT is one of the least malignant surgical subspecialties. And so I actually had a really great experience, and I loved like 95% of the interview trail that I met, and the other 5% I just didn't get to know. So I think we're blessed in that, but you want to be at programs that they're supportive of whatever you want to do. So they're supportive. You have female residents there. It's not just a program of all white men, which there are programs.
Thank you. And after everything else, after a question to you, it was what kind of things matter in the residency? As I'm a 4th year applying, we have participants who are 4th years applying. What are those kind of qualities that we should hopefully be trying to feel out from different programs that really matter to our experience? Alas, the wheels of technology come for everybody, it seems. Question from the audience participants, but can you speak to a day in the life of an otolaryngologist ENT resident?
Sometimes you wake up, you come to work, sometimes you have cases, sometimes you're in clinic, sometimes you're at the county, sometimes you're at the VA. It kind of is really dependent on what rotation you're on, and I guess what program you're at. But like for me, typically I show up, I pre-round, I get everything, all the information ready. I'll round with the team. We'll do whatever things we need to do. If it's a trach change on rounds, if it's just a dressing change, if it's just seeing them, laying eyes on them. And then we come back. Typically, sometimes we have journal club, and then we have like some people go off to cases, and then some people go to clinic, and then end of the day, same thing, PM rounds. Throughout the day, I'm the intern, so I hold the pager. I go see the consults, and then I come home and do it all over again.
Sounds fun. Yeah, I can't wait.
Yeah, my experience is fairly similar. I'm at the county hospital right now. I'm actually in a conference room. I'm going to go PM round after this, actually, with my chief. But yeah, it's my team right now is just me, 2nd year, and then my chief, who's at 5. But some teams have an intern. Some teams have 4 or 5 residents on it, depending on how big the service is. But typically, morning's always going to start with rounds on your inpatients. The intern is usually responsible for making sure we have all the supplies for rounds, like Otafe alluded to, for dressing changes. Oftentimes, the intern is also in charge of knowing all of the numbers, whether it be the labs, the vital signs, kind of the intern, exactly. has to know kind of the ins and outs of all the patients. They are the primary doctor for that service. And then the rest of the team is there to support them. The chief is definitely overlooking that very closely. And obviously the attendings are checking the charts as well. But that's an important role as an intern. And then, yeah, it really varies. Members of the team might be assigned to clinic or OR for half the day or for the full day. And so you're kind of running around doing that. And then usually it's a junior resident, either the intern or the PGY2, depending on the program, that's holding the consult pager. So if the internal medicine team or the orthopedic surgery team has an ENT issue of some sort, then you're going to sort that out. You're leaving the clinic or the OR, or you're going during lunchtime, if you have lunchtime, to go and see the consult, to scope the patient, to whatever the case might be, and figure it out. Talk to your chief, talk to your attending or the fellows about the case, and come up with a plan of attack for that patient's care. And then usually it's the intern who's holding the pager for the floor, taking care of the inpatients on the unit. And then after that whole day of taking care of consults, holding down the floor for the patients. So if you're calling consultants for your patients that you're primary for, talking to social work, speech language pathology, we work with very closely, PT, OT, all those things. And then at the end of the day, PM rounding, going back and seeing your patients, your inpatients on the unit, wrapping things up, documentation, and then usually once a night a week or in the morning in the week, depending on the program, you might have lecture, journal club, what have you, and then get home. You know, hopefully you get a couple hours to do some things. It depends on the night, depends on how late the OR goes, and then hit it back again the next day.
Busy. Booked and busy.
The nice thing is though, clinic and ENT, a lot of procedures, a lot of scopes. It helps. Like for me, ENT clinic was the most fun clinic I did in med school. And that was another thing that sold me on ENT, because you're not just writing notes and seeing 50 patients.
Exactly. I scope and I do biopsies and I clean ears, and I love cleaning ears. I'm not even gonna lie, it's so therapeutic. So it's actually a fun clinic.
Dr. Alexander, if you're able, would you have anything you want to add to that?
So my day is not the typical day in that I'm on a surgical subspecialist functionally. So my day is not at all like the comprehensive otolaryngologist, but that's a little bit more like residency. But what I do is, like today, it was a lot of voice-focused care and airway-focused care. And being program director, that is a 25-hour-a-day job.
Hey, what are the times we cut out? I will say the plus side of all this panel, as tragic as the technological difficulties are that she shared her Instagram and email below. Oh, she's back. I spoke too soon. Take it away, Dr. Salander.
Since I'm having so many troubles, I want to unfortunately skip over questions and provide two important bits of insight. Number one is, remember when you all were talking about networking, there is a network. I don't know if you know the name Harry Barnes, but Harry Barnes was the first African-American certified in any surgical specialty in the United States. And he was an otolaryngologist. And so otolaryngology head and neck surgery, our section in the NMA is also a separate entity called the Harry Barnes Society. And so if you email Harry Barnes, HarryBarnes, capital OHNS, at gmail.com, that goes to our executive committee, and that is a wealth of physicians who have walked uphill both ways in the snow to get to their otolaryngology training. And that is the network that you should be plugging into. That is the network where you should be looking first to make your clinical impressions and also for research opportunities. Every year at the NMA meeting, we have a scientific symposium where medical students and residents have the opportunity to present their scientific work, and we award prizes, as well as we do provide financial support to attend the meeting. This year, we're doing a virtual Grand Round series. Our first talk was Healthcare Inequities and Social Justice, and it was by Bobby Seale of the Black Panther Party. And we talked a lot about how health is a part of liberation. and inclusion in any society. And so please go to the Harry Barnes Facebook page, where pretty much all of our events are listed there. We are working on developing a Twitter and our own independent website. That's correct, at gmail.com. Gmail. And the other thing I wanted to say is about research. The point of doing research is not to cure any condition as a medical student. The point of doing research is to prove that you have the capacity and the willingness to take a project from beginning to end and remain committed to it. And so the subject matter almost doesn't matter. At most programs, there's a select few programs who only want otolaryngology research, but that is not the vast majority of programs. They want to know. I matched, my project was in orthopedic surgery because that's what I thought I wanted to do when I came to medical school. And then a third thing, just kind of to ground it in reality, there is no glass slipper of a program. You're not going to necessarily show up to the many webinars on headmirror.com ball and find the one that is your perfect fit, that recognizes you and you recognize it immediately. There is the potential to flourish and bloom where you are planted, but obviously you don't want to pick the most adverse soil available. But there's great training to be found at programs that may look a little bit imperfect to you. As far as things like program responsiveness to resident feedback, I would ask you all to keep in consideration that not everything can be changed immediately. So sometimes, my residents are fantastic and enthusiastic. They'll report something on a Wednesday and 2 weeks later ask me when the implementation is going to be. And if it's a federal or hospital or ACGME based guidelines, sometimes those things can take a long time to change in your perspective. But you have to keep in mind that we are working within a number of constraints, and so it's not always that the program is not responding to the feedback. It's that they're doing what they can inside of the construct that they need to work in. So I do want you to know that. This is not marriage. This is a 5-year dating experiment, more like. Like you're going on to Otolaryngology Island and then you'll go back to Otolaryngology World. It doesn't have to be absolutely perfect for you to get what you want and need. I would also say that just as a warning, the word on the streets is all skin folk ain't kinfolk. Some of my strongest allies over the course of my career don't look like me. And so do not isolate yourself into a silo. Particularly right now, we have a lot of faculty who are becoming more conscious of the uphill battle that many underrepresented minority students have been experiencing. I'm sorry, not underrepresented minority, minoritized students who have been pushed into the minority in these contexts. So they're becoming more aware of what those difficulties that we have faced are. And there are people who are absolutely willing to share their clinical expertise and teaching, and they want to listen. So speaking as a faculty member, if you ever encounter a minoritized faculty member who seems like they're not giving you the time or the space that you need, I would ask you to consider that we are also experiencing the same oppressive forces that you are experiencing. And so the reason why the one Black faculty member does not have a lot of time to mentor every single person is that they may be facing struggles that they're hiding from you or that they are fighting through just to survive to be in that practice. And so I would ask for compassion on them as they are paying the tax both in the mentoring area, and they're also paying the taxes of having to outcompete their colleagues clinically. So that's that. Harry Barnes Society, that's my main thing, is to advertise Harry Barnes Society.
I gave out the applause too soon before. I'm sorry, Otterfa. Thank you so much for that wisdom. Just to review, Harry Barnes, HarryBarnes, OHNS @gmail.com. Perfect. I actually really do like the Gamail. I'm going to take that with
Yes,
me.
that's
Um,
a gift from the 70s.
I want to ask for Dr. Howard and Dr. Saturday, since Dr. Alexander gave us so much, a line of wisdom. I know all of it has been dropped. Watch your step when you get up. But if you got anything else you want to add, if not, just tell me the favorite thing you've pulled out of an ear or nose or throat in your in your clinical practice so far.
I don't have wisdom that's going to match up to that. I think it'd be inappropriate to try to follow that with any kind of wisdom at this point in my career. But I did pull a variety of things out of one nose. It was a 2-year-old child who had stuffed there was a piece of a plastic like clip or something. We thought that was the only thing in the nose. Then I kept looking. There was a balled up like apple sticker from like an apple or a fruit. And then there was a piece of a playing card. So this kid was a serial nose stuffer, and the left side of his nose had like 3 or 4 different things in it.
Dang.
And then one of them actually had fallen back, so we had to DL the kid too, direct laryngoscopy, for those of you who don't know yet, because one of them I actually ended up pushing back, into the throat, because as I was looking, I didn't realize there were so many things in this kid's nose. And so I think this kid might need to see a psychologist or something, or maybe it's just part of that developmental stage, and he really likes the
He's
feeling.
just building a Costco, is what he's doing.
I don't know. But so,
No.
foreign body retrieval can be a fun part of being a junior resident on call, or maybe even an attending.
Yeah, I haven't pulled much but hearing aid buds. So I'll agree with everything Dr. Alexander said. I think that is a tragedy that we're having such tech issues, because I wish you could have been dropping that kind of knowledge the whole time. But I will just reiterate to people that don't have a program or don't have like the support system or the mentorship yet, that if ENT is something that you want to learn more about, do it. We are here for you. If ENT is something you want to do and you feel discouraged and you don't have mentorship, but it's what you're passionate about, keep in mind that it's a career. This is not something that it's just like your path. If ENT is your dream and your goal, then you will get to it. It just might not be the same cohesive path that you anticipated. And keep in mind that if it doesn't work out for you, or if there's a moment where you feel like you have to take a research year, it's not the worst case scenario. 1 year in between isn't going to change your 40-year career. So if it's something you're passionate about, like, believe in yourself, you can make it happen. We're here to help facilitate it. So just don't be discouraged if you don't have that type of support.
Thank you. Not just to you, but to to you.
Wait, before we go, I pulled a seed burr out of a patient's larynx while they were awake in the ED. They were harvesting hay, and it was a husband and wife. They were harvesting hay, and they crud. What happened? Oh, a gust of wind came by right when she was inhaling, and she felt something on her lip, but then it made her gasp. And she inhaled a sticky burr, like the kind that stick to cows and everything. And so she had been sent home from another ED that didn't have otolaryngology care. And then my team scoped her, and I went down to the ED with my PGY4, and I was like, all right, so this is a laryngeal forceps. They used to use it for biopsies. We're going to take out this seed. We numbed her up with Lido, and my PGY2 held her hand and looked her in the eyes and just gave her the biggest coaching talk. And we reached in and we pulled it out. And I think it's on my Instagram. So all the more reason for you to go to my Instagram. And that was like 8 hours after I had taken a June bug out of somebody's ear too. We have wide open prairies down here.
This is a great endorsement for Houston. I promise it's not just bugs and seed birds. There is more. There's real city. But yeah, thank you so much again to our amazing panelists. Even just me as a semi-moderator, I've just been learning so much. So thank you so much for your support of the SMA and our membership. For everybody watching, if you could scan the QR code that's about to pop up on screen, magically so. this would be super useful for us. We're getting some feedback, creating more useful programming for you. You can scan with your fancy phones or type the link that'll be, or copy the link that'll be in the chat. If you could follow us on Instagram at SNMA official, sorry, SNMA_official, on Twitter at SNMA, and like us on Facebook. We're everywhere, large footprint. But more importantly, if you're not a national member, you should become a national member. It's how you can hear about events like this, learn more about the Herringbone Society, get connected with people in this network. So go to snma.org, find out how to become a member. And thank you again for tuning in. We got some upcoming events on the left. That'll be September 9th, ophthalmology, transplant medicine on September 16th, and pathology on September 23rd, excuse me. I think that's all I have for you tonight. I've been your host, Hope Yoder. I didn't come with a good sign off, so this is the sign off. Have a good night, everybody.